Guys, this is Mobeen. We are talking about the pathologies of the pulmonary system. The disease is the bronchiectasis that we are discussing. The definition of the bronchiectasis is chronic, permanent dilatation of the bronchi and the bronchioles due to or associated with chronic infections that cause destruction of the airway walls. So that is the definition. This is irreversible disease, and normally obstruction and infection are present together. It is possible that infection appears first and that causes pus formation, which results in the obstruction of the pathways due to the pus or the inflammatory exudate, and then causes the bronchiectasis. Or it is possible that there is obstruction first that leads to stagnation of the airways, which causes infection, which causes inflammation, which causes destruction of the airways. But these two things are present together always, obstruction and infection. So now let's see, after the definition, epidemiology, important from STEP's point of view. In the United States, the most common cause of the bronchiectasis, in United States, the most common cause of bronchiectasis is cystic fibrosis. Worldwide, the most common cause of bronchiectasis is tuberculosis. So keep that in mind. From a pathogenesis point of view, what is the pathological mechanism? Here is what happens. Remember this, at the end of the day, there is going to be infectious process. There are going to be infections. Infections will lead to inflammation. Inflammation will cause local tissue destruction, causing exudate, plus destruction, tissue destruction. Now this destruction will mean dilatation. However, exudate will cause obstruction. This obstruction will increase infections so that this process continues to occur till we reach this branch and reach the dilatations, which is the bronchiectasis. Now let's start with the cystic fibrosis, the very first one. All of these diseases are going to end up with the infection causing destruction. Cystic fibrosis. Cystic fibrosis is a disease primarily of Caucasians. Again, as I said, most common in the United States. Unfortunately, the disease progress is such that by 30 years of age, patients have actually died because of respiratory failure or heart failure due to the respiratory failure, cor pulmonale. What happens in the cystic fibrosis is following. So if we come here, I'll make that over here for a second. In the cystic fibrosis, let's say this is a normal cell, the cell which is making the lining of the respiratory system or lining of other mucosal membranes. So this can affect the GIT, respiration, and other systems too. This is a cell. The cell has chloride proteins, chloride channels, which allow the chloride to go out and allows the sodium to come in. And you know that when sodium comes in, water also comes in, right? Now, if this cell, which allows this chloride to go out and sodium and water to come in, if you pick up this cell and put that over here and imagine that this is the chloride channel and this is sodium, let's call it half and half, sodium and water channel. Normally what would happen is chloride would be secreted, sodium and water will be reabsorbed, and there will be an eventual layer of secretion that will be formed here, right? So this is the normal moist layer. Now we also know that these cells have gotten cilia all cells have gotten cilia here. These cilia will keep beating and keep moving this layer, the moisture layer, upwards till we expectorate it. So we either swallow it or we throw it out as phlegm. What is the benefit of this moist layer? The pathogens, the allergens, the dust, the smoke, such things get trapped over here. So it is important for us humans and other animals to clear the bronchial pathways by using this mucociliary elevators or escalators. Now what happens is, when there is a problem with the cystic fibrosis, we call CFTR gene. When this gene has a mutation, that causes this chloride channel to become defective, this protein to become defective, and chloride extrusion stops. So when that stops, chloride stays in the cell. Also, the sodium reabsorption and water reabsorption increases. So think about it now. What would happen is, ions are not going out, which will trap the water. Chloride is not going out, but more ions are coming in and water is coming in or is reabsorbed from the lumen. The result of that is that this is isotonic fluid. I said isotonic fluid. When CFTR is present, the sweat will become hypertonic. We will discuss that in the CFTR lecture or cystic fibrosis lecture. Here, please remember, this secretion here is isotonic because sodium and water both are reabsorbed. However, the problem is that this secretion has now become thick. Why? Because of the extra reabsorption of water and sodium. This thick, viscous, V-I-S-C-U-S, I believe, viscous or C-O-U-S, C-O-U-S, this thick, viscous secretion here becomes an obstruction for the mucociliary elevator to work properly. Cilia cannot easily move this thick secretion up towards the upper pathways. This then causes stagnation in this area. It would cause then the thick things to start obstructing here, number one. Number two, there will be, of course, infections that would start, inflammatory process would start, because there is all the junk that was coming in is trapped in here. So that is what happens with this CFTR. That is the most common cause of the hereditary problems, cause of death due to hereditary problems in United States in Caucasians. 98% of the people with the bronchiectasis due to CFTR are Caucasians. Okay, so this is one. Then is the chronic infections. Similar system, if somebody has chronic tuberculosis or other infections, for example, if a patient has immune globulin deficiencies, that would cause various pathogens to be present and repeatedly attack the respiratory system. That these continuous infections will cause the same thing, that slowly the pathways, so this is a normal bronchus. What do we have here? We have gotten in this bronchus the inner layer. These are the pseudo stratified columnar epithelium, which is ciliated. This epithelium, then we've gotten the muscular layer, cartilages may be present, and then we have the adventitia. This is normal. However, with the continuous infection, what will happen is, if I make one more over here, side by side, there is going to be destruction. So let's say this area is destroyed. There's going to be destruction of the lining and the muscle and the cartilage, and dilatation of the airway. Right? So now this destruction in the beginning is usually just on the inner side, and that inner epithelial lining becomes refurbished, it becomes regenerated, and it is okay. But when this infection becomes repeated, then finally the wall starts destroying. Once the wall is destroyed, once again the mucociliary system is now not working over here. That will result into accumulation of the pus, exudate, and the secretions. So that would cause obstruction. So dilatation, destruction, and obstruction. So this is the chronic infections, for example, tuberculosis. Then is the bronchial obstruction. So imagine this, as I said before, obstruction and infections are present together. Any one of them can come first. So for example, it is possible if we obstruct this area. How do we obstruct it? We can do that by a couple of things. One is we can cause tumors. Mostly the proximally located tumors that press on the airways will cause that part of the airway which is being supplied and is obstructed now. That area, for example, if this is the obstruction, then this area which is dependent, that area would start developing stagnation. Mucociliary system will not be able to clear the mucus from here. Infections would start developing, secondary infections, and that would then cause destruction. Remember, bronchiectasis is a secondary disease. It is not a primary disease. It occurs after these problems as a secondary issue. So foreign bodies can do this, tumors can do this. Then in allergic conditions or continuous infectious conditions, these obstructions can actually be the mucus plugs that would obstruct the pathway. Then the distal areas will develop infections and destruction of the tissue, and that would cause the dilatations. Cartaginer syndrome or primary ciliary dyskinesia, that is a problem directly with the cilia itself. So see, these cells, all of the cells in here in the respiratory epithelium have gotten cilia which would work with the mucociliary as a mucociliary, as part of mucociliary elevator and move the mucus up. What will happen if these cilia are not working correctly? If they are not working correctly, mucus will not move up, and the same problem as we saw here will occur. So how can that happen? Let's look at the structure of a cilia. So let's say this is a cilia. The cilia has got 9, so 1 pair, 2 pairs, 3 pair, 4 pair, 5, 6, 7, 8. I have to make 9 pairs. 9 pairs of microtubules. So these are microtubules. And there are 9 such pairs on the periphery. In the center of the cilia is also 2 singlets of the microtubules that are connected with each other. Now outside the cilia that you're seeing, the microtubules that you're seeing, these microtubules are connected to each other through the nexin proteins. So this is another set here. This is one more. So these microtubules are connected, I'm going to make that in green, by nexins. These microtubules also have dynein arms attached on the outer side, 1, 2, 3, and attached on the inner side. So if I make that cross section over here, how that would look like is, this is the cilia, these are the pairs, 1, 2, 3, 4, 5, 6, 7, 8, and 9. These are connected to each other through nexin. Then they have gotten the dynein arms outside and inside, outside and inside. These dynein arms, these red ones, and of course there is the central system as well, and there are spokes coming in from here like this. Important thing is to note that these arms, dynein arms, they use ATP energy and they move, and when these red ones move, they cause this whole big cilia to move as well. That is how the cilia beat or move. Now in the Cartagena syndrome or primary ciliary dyskinesia, what happens is that these dynein arms are either absent totally, or one of them is absent, or the other one is absent, or there is a problem with the structures, the ATP pumps over there. The result of that is that cilia is present, but cilia will not move. Now, when cilia will not move, we'll have a lots of problems. If this is a male, you would see he'll have a problem with hearing because cilia are needed for the hearing. He will be infertile because cilia are needed for the sperms to move in the vas deferens, and that patient would develop respiratory infections, repeated respiratory infections. Why? Because of the Cartagena syndrome, these cilia will not move, and because they are not moving, the mucus present here would just stay stuck here, and that would cause infections to appear here. That would then cause inflammation and destruction. So if you see here, in all of these causes, may it be allergic aspergillosis or Cartagena or bronchial obstruction or chronic infections like tuberculosis or cystic fibrosis, all of them ultimately end up into the infections, and that finally causes this pathology of obstruction and destruction. Cool. So that is the pathogenesis. Now, what are the findings? Look at this, guys. Findings are simple. When there is destruction of the airways, growth, if you look at the lung, you would see that the lung has, so if this is the lung, this patient's lung, you will be able to see big blebs and big dilatations filled with pus going all the way up to the pleural surfaces. Normally in the gross examination, 2 to 3 centimeters away from the pleural surfaces, you can see the airways, but then you cannot see them. They become so small that microscopic observation can be done, but naked eye observation is not possible. However, in bronchiectasis, they become so dilated, normally in the lower lobes, and they become so dilated that you can actually trace the dilatations up to the pleural surfaces. Dilatation can be of two types. One are saccular dilatations. These are, if I make that here, actually let me make that here, sac-like dilatation, or tubular, in which the dilatation is like this. It's a big long tube, or it could be saccular. So saccular or tubular dilatation can be formed. Now, so we've talked about that. Clinical is very simple. Look, what is the basic problem? Infections. So chronic repeated infections which would need antibiotics. Pus will be formed here. The patient will actually throw out cup full of pus. So expectoration, productive, putrid, smelly expectoration is common. Then hemoptysis, there may be flecks of blood or there may be frank bleeding, and again that is from the destruction. So cough, sputum, hemoptysis is possible. Then the clubbing of the fingers will develop, and the most important thing is, because of the continuous infections and destruction of the lung tissue, the cor pulmonale would develop, or the right heart failure would develop because of the pressure or pulmonary hypertension. So heart failure. Normally these patients who have bronchiectasis, maybe because of the CFTR or the Cartagena syndrome, mostly the CFTR, normally these patients would die by the age of 30 because of respiratory failure or because of the heart failure. This is how serious this problem is. How do you treat this? Of course, you give the antibiotics to handle the infections. Haemophilus influenza is common, streptococcus is common, pneumococcus is common, staphylococcus is common, Pseudomonas aeruginosa is common, adenovirus is common. So these are the commonly occurring pathogens that cause the repeated infections. Of course, you give antibiotics for infections, repeated infections. If it is TB, you control that. You can give bronchodilators. You can give deoxyribonuclease aerosols for this, and of course try to fix the underlying cause. If it is a tumor, then treatment is needed for that. Of course, if there is a foreign body, we need to work on that. Or if there is any other such reason that you can handle, you will have to, nowadays there is pulmonary rehabilitation and physiotherapy as well that is being used to help the patient.